Hi, good evening everybody. I'll be talking about oxygen devices. Most of you are familiar with the topic. These will practically form your questions, some of the questions in practical exam. I'll keep it simple. So first, looking into the purpose of oxygen therapy, we use the oxygen therapy predominantly to address the hypoxemia in the blood. So hypoxia, which is the lack of oxygen at the tissue level, and hypoxemia, which is the lack of oxygen present in the blood. The hypoxemia is characteristically defined as a PaO2 which is less than 60 or a saturation which is less than 90%. These are the main indications for starting the oxygen therapy at the outset. So the indications for oxygen therapy include if there is an increase in the oxygen consumption which could be due to convulsions, due to thyrotoxicosis, shivering, pyrexia, commonly seen situations where there is decrease in alveolar ventilation which could be narcosis, CO2 narcosis or a hepatic coma or a drug overdose, increase in the barometric pressures like high altitude sickness, pulmonary embolisms, etc., leading to VQ mismatch. There is an anatomical shunt left to right, decreased perfusion because of some peripheral vascular diseases, or there is a decrease in the hemoglobin concentration because of some anemia or histotoxic anemias because of some poisonings. The oxygen therapy can be divided into orthobaric and hyperbaric. Now there are various classifications for the devices for oxygen therapy. They can be based on designs or they can be based on performance. On the basis of designs, they are low, medium and high flow systems and enclosures commonly used in pediatric patients, or they can be performance based, which are usually either fixed performance devices or variable performance devices. Now I'll first be talking about the variable performance devices which include low flow, which are commonly used things like nasal cannulae, nasal catheter or a transtracheal catheter. Then the reservoir systems, which is the simple face mask or the partial rebreathing mask or non-rebreathing mask or a tracheostomy mask. Then high flow or fixed performance devices, which are usually the Venturi masks or the blender devices like HFNC, etc. Now oxygen delivery systems divided into normobaric and hyperbaric, again low, medium and high dependency, then low dependency devices further divided into variable and fixed performance devices. The low dependence devices are usually the a low dependency is the situation where the supplemental oxygen is required by the patient, but the patient is predominantly spontaneously breathing. In a medium dependency, along with oxygen, a partial support like a CPAP support may be required by the patient. And high dependency is where the respiratory support with an NIPVV or an IPPV mode is required for the patient. Now, how do we choose the method of delivery for oxygen therapy? Whether it is dependent on the degree of hypoxemia the patient is having, the kind of state the patient is in, how much precision you need in the delivery of oxygen, and most importantly the patient should be comfortable with the methodology. So now the low dependency and the high flow oxygen devices vary. Low dependency cannot deliver a constant FiO2, whereas in high flow oxygen devices there is a constant maintenance of oxygen that is there. The flow and low dependency systems is usually between 6 to 8 liters, whereas in high flow devices the oxygen is delivered at a very high flow rate. In the low dependency systems, the FiO2 can vary with the patient. The tidal volume the patient generates, the respiratory rate of the patient, all these things can vary the oxygen delivery to the patient, whereas in high flow, these things are more or less fixed. The common low flow devices are the nasal cannulae catheters, the transtracheal catheters and the various types of masks. Now coming to the simple nasal cannula, we all know we have been using it. Usually these nasal cannula consist of nasal prongs connected to an oxygen supply tubing. The flow rate is mostly 2 to 4 liters and the FiO2 delivered is about 0.2 to 0.3, 0.4 in a patient. For every liter increase in the oxygen, you can raise the FiO2 by about 4%. In these, the nasopharynx acts as a reservoir for the oxygen. The patients which are predominantly mouth breathers, in these if we apply the nasal prongs, then the posterior part of the nasopharynx typically acts as an entrainment for the oxygen and hence maintains the saturation. It is available in various sizes and shapes. They can be flared, they can be curved. The advantages are it is very easily tolerated by the patient, it is lightweight, it is comfortable, the day-to-day activities of the patient in terms of eating and drinking are possible, no humidification is needed, and it is very low cost. The disadvantage again is that sometimes it can cause trauma, very high flow are irritant, they can be crusting and bleeding, and the FiO2 of course varies with the respiratory rate. Then a nasal catheter. Nasal catheter is a soft tubing which goes through the anterior nares and is lodged just above the uvula. So the distance is usually measured from the nasal ali to the tragus, and it delivers about 2 to 3 liters of oxygen. I couldn't find any real indication for putting any nasal catheters. Some of the books have described that it can be used in procedures like bronchoscopy, etc., where the oxygen is required and nasal cannula are not well tolerated by the patient. The downside is it is a single catheter, so it can get blocked, it can cause gagging, there is a lot of air ingestion, and so it can cause gastric distension in the patients. Then comes the simple face mask. It has an oxygen inlet and expiratory exhalation ports. It is a transparent device and it has a reservoir capacity of about 100 to 250 ml. Different oxygen flow rates result in highly variable and unpredictable FiO2 that reaches the patient. The other downside is that on rebreathing, if the flow rates are very low, then there can be rebreathing of CO2 that can happen with this mask. About 4 liters per minute of oxygen flow is required to maintain an FiO2 of 0.35 to 0.4 and to maintain an optimal oxygen delivery to the patients. The flow rates greater than 8 liters per minute are usually ineffective. The advantage is again very easily available, it is less expensive and can be used in mouth breathers also. Disadvantage is some patients can experience claustrophobia, it is difficult when the patient is eating or drinking, cannot really deliver very high FiO2s, and in low FiO2s can cause the retention of CO2. Then coming to the partial rebreathing mask, it is again more or less like a face mask only with a small bag with the capacity of about 600 ml to about 1 liter attached to the mask. The mechanics is when you are inspiring, the 1/3 of the exhaled air which is in the reservoir plus 2/3 of the fresh oxygen is inhaled by the patient, and when the expiration occurs, 2/3 of the exhalation escapes with little bit of oxygen. So these are the basic reservoirs that exist in a reservoir system. Our anatomical reservoir in a spontaneously breathing patient is the nose, the nasopharynx and the oropharynx, and the combined capacity is about 50 ml. So it is about 1/3 of the dead space. The face mask has a capacity of about 100 to 200 ml of reservoir, and the bag has 600 to 1 liter. Now, the partial rebreathing mask delivers usually an FiO2 of about 0.6 to 0.8. A minimum of 8 liters is required to maintain the fresh gas flow into the mask and to avoid the entrainment of CO2. The flow rate in the bag or in the device should be sufficient to keep the bag at all times about 1/3 to half filled. So these are the various flow rates at about 6 liters, 0.6 FiO2, and even at 10 liters, it is almost impossible to deliver an FiO2 more than 0.8. Now the non-rebreathing mask is more or less similar to the partial rebreathing mask, except that instead of the expiratory ports, here is a one-way valve. So only exhalation can happen, no inhalation can happen from there, and the FiO2s of about 95 to 100% can be achieved with 10 to 15 liters of oxygen flow in this. So there are the expiration valves. The inspiration valve is there, only unidirectional flow of gas is possible, and there is an oxygen feeding line as you can see in the picture. Higher oxygen supply rates are required in this. It is desirable in cases where the rebreathing of carbon dioxide would be detrimental, particularly in head injury patients. Best results will be achieved with adequate flow rates when the reservoir bag does not empty more than 1/3 of its capacity. The advantage is that a very high FiO2 can be delivered to a spontaneously breathing patient who have severe hypoxia. The disadvantage is it is slightly more expensive. It requires quite a tight seal. So for some patients may become claustrophobic or find it difficult to manage. Interference with eating and drinking becomes difficult in patients who are severely hypoxic, and it is not suitable for long-term use, and if it is not used appropriately or one of the parts is not working properly, then there can be a CO2 buildup or some kind of suffocation may be felt by such a severely hypoxic patient. So now depending on the flow rates, if we are requiring oxygen say about 1 to 6 liters per minute, the nasal cannula will deliver an FiO2 of about 0.2 to 0.4. A transtracheal catheter again will deliver to about 0.2 to 0.4. An oxygen mask can deliver from 0.4 to 0.6 FiO2, and a reservoir can go up to 100% also. The non-rebreathing up to 100%, the partial rebreathing up to about 0.8. Now the high flow or the fixed performance devices. These fixed performance devices basically work on the principle, the Venturi modification of the Bernoulli principle. Now in Bernoulli principle, when a gas is flowing at a very high velocity through a tight orifice or a thin orifice, then there is a lateral decompression that happens on the sides, and a subatmospheric pressure is created through which the entrainment of the atmospheric air happens. So a fixed amount of gas, which is the oxygen, flows through a terminal, and the rest of it is mixed up with the entrainment of the atmospheric air, making it possible to give a fixed delivery of oxygen. The more air is in, so here 100% oxygen inlet is there, and on the sides through the openings the room air enters, and this combined air is delivered through the mask. It delivers a fixed concentration of oxygen. The size of the constriction determines the final concentration of oxygen for a given flow. So the tighter the orifice, the more the atmospheric air will enter, and the lesser the FiO2 will be achieved by the patient. So FiO2s can be 0.24, 0.28, 0.31 depending on the device, on the size of your venturi. Because of the high fresh gas flow rate, the exhaled gases are rapidly flushed out from the masks. So there is no rebreathing or no retention of carbon dioxide that happens in this device. These masks are recommended when fixed oxygen concentration is desired by the patients and ventilation is dependent predominantly on the hypoxic drive of the patient. So depending on the kind of FiO2 that you want to deliver to the patient, the color coding of these venturi devices is there. These venturi devices can be attached to the tracheostomy tubes also when we need to deliver a fixed FiO2 through the tracheostomy tube. And there is an adjustable venturi valve also, which one valve can be used to change the requirement of oxygen as per the desired amount. So the advantages, again, there is a fine control of FiO2 at a fixed flow. It is reliable, it is fixed. High concentrations from air can come into this, so it saves the oxygen cost. And disadvantages is sometimes uncomfortable, expensive, cannot deliver very high FiO2s. Now come the blending systems. The blending systems predominantly work on the principle where the oxygen and the air is mixed by an external device or a generator, and then at a very high flow rate it is sent to the patient. So the commonly, particularly in this era of COVID and these acute viral illnesses, about all hospitals have been using these HFNCs or high flow nasal cannulas, which predominantly work on these principles. The gas flow rates can be as high as 60 liters per minute, and a fixed FiO2 can be delivered to the patients. The advantage is this, that there is always a humidifier with a temperature control attached to these devices. The humidified air, which is temperature controlled and comfortable to the patient, can go through these devices, and because of the high inspiratory flow rates, there is no entrainment of CO2 that occurs in these devices. So this is the picture of a HFNC setup, and there is a gas source, then there is a humidifier, and there is a generator which blends the gases, and then these cannulas are placed onto the patient, and the humidified gas is delivered to the patient. It minimizes the atmospheric entrainment and enables a constant and a predictable FiO2. Most devices allow a maximal gas flow as high as 60 liters per minute, and the FiO2s can range from 0.2 to up to 1 liter. The HFNC generates a positive pressure in the airways. So sometimes you feel that there is a loss of PEEP effect in these patients. So there is a small amount of PEEP that is generated by HFNCs, and it depends on the flow of the gas that we are giving. If we are giving say about 40 liters flow, then an average PEEP of about 3 mm is there, and a maximum PEEP of say about 5 or 6 can be generated with 60 liters per minute of flow. But yes, if the patient predominantly keeps the mouth closed, this generation of PEEP is much better. Coming to the enclosure devices. These enclosure devices are predominantly used for infants and neonates. These are oxygen tent, hood and incubators. The oxygen tent delivers about 40 to 50% of FiO2, 12 to 15 liters of oxygen is required. It is usually maintained at a temperature comfortable for the infants, and it can be used in concomitant aerosol therapy also. The disadvantages are it is expensive, the hygiene is difficult to maintain, there is a constant leakage, and of course limits the mobility. The oxygen hood, it covers only the head of the infant. The high FiO2s of up to 100% can be delivered through this, and a minimum flow of 7 liters is required to prevent the carbon dioxide accumulation. The purpose of this enclosure devices was just to familiarize you once. Incubators, again used for very small kids, and the FiO2s of about 40 to 50% can be achieved, and a flow rate of about 8 to 15 liters per minute is required. Coming to the hyperbaric oxygen therapy. Hyperbaric oxygen therapy is when the patient breathes 100% oxygen at a pressures which are greater than 1 atmosphere absolute. So the physiological effects of hyperbaric oxygen therapy, when we are giving hyperbaric oxygen therapy, there is an increase in the blood oxygen content. There is vasoconstriction because of the inhibition of the nitrous oxide. The antibacterial action also is there for HBOT. There is inhibition of endothelial neutrophil addition, and because of the bubble reduction, there is further relieving in the hypoxemia. The indications for hyperbaric oxygen therapy are decompression sickness, air embolism, carbon monoxide poisoning, severe crush injuries, and some of the chronic indications include the radiation necrosis, some diabetic wounds, and osteomyelitis. The contraindications to hyperbaric oxygen therapy are usually untreated tension pneumothorax, and the disadvantages are that it can cause, because of its pressures, can cause some ear and sinus trauma. It can lead to the rupture of tympanic membranes and can cause pneumothorax. With oxygen, always risk of fire hazard is there. It can be claustrophobic. Sudden decompression can be there, leading to problems. There is a problem in communication. Then the long-term oxygen devices, which we often prescribe to the patients, usually they are oxygen concentrators. They are stationary. The principle of oxygen concentrator is that it takes up the air from the atmosphere, it compresses the gas, and then a titrated gas can be released, titrated oxygen can be released to the patients depending on the requirement. They can be up to 5 liters or 10 liters oxygen concentrators depending on the requirement of the patient, and usually the delivery devices are either nasal cannula or reservoir nasal cannula. These are the reservoir nasal cannula. They are attached with some reservoirs to them. They are supposed to have a better and a more constant oxygen delivery to the patient. Transtracheal catheter, it is usually inserted through the trachea. Not much of a use generally. There are few advantages. It is not irritant in the nares or on the face. There is infrequency of catheter displacements. Oxygen requirements of up to 50% can be given. Multiple disadvantages. Mucus balls can get stuck in it. It can cause infection. There can be a catheter breakdown. Now, how do you choose or select the device that we need to give the oxygen therapy? There are 3 P's to it. There should be a purpose for giving the oxygen therapy, the kind of patient, and the performance of the device. The goal is ultimately to keep the patient comfortable and to match the requirement or the end result that we are needing. So the severity and the cause of hypoxemia, the patient age group, the degree of consciousness and alertness, the presence or absence of tracheal airway, stability of minute ventilation are some of the things which will make us decide on the route for which the oxygen delivery method should be chosen. So classifying them, if we are requiring a low delivery method, then if there is a variable delivery mode required, then it can be a nasal cannula, a nasal catheter, or a transtracheal catheter. If a fixed FiO2 needs to be given, then it can be a Venturi mask. Again, for medium requirements from about 35 to 60%, a simple oxygen mask or an air entrainment device with a Venturi mask or a blending system can be used in the patients with fixed requirements. For high requirements more than 60%, it is either a partial or a non-rebreather mask and blending system for a fixed requirement. Now, the dark side of the oxygen therapy, every therapy has its own dark sides. So, for oxygen therapy, the dark side is the pulmonary oxygen toxicity or the Lorentz-Smith effect, which usually occurs between zero point 0.7 to 3 atmospheres. It is usually dependent on the duration of time you have for the exposure to oxygen and the amount of oxygen that the patient gets. Usually leads to the damage of the capillary endothelium, leading to pulmonary fibrosis, decreasing the vital capacity of the patient, and ARDS-like state can appear. Vital capacity of the patient is reduced. Then CNS toxicity of oxygen or the Paul Bert effect occurs on breathing oxygen at a pressure greater than 1 atmosphere. Usually there are tremors, twitchings, and can lead up to convulsions also. There is depression of ventilation. Absorption atelectasis can occur because of the washout of nitrogen from the alveoli, leading to absorption atelectasis or the collapse of the alveoli. So imagine if trees gave off Wi-Fi signal, we'll be planting a lot of them and we'd probably save the planet too. Too bad they only produce oxygen. So let's plant trees. Thank you. The lowest percentage of inspired oxygen is delivered by? Good. So, in a patient on oxygen therapy who is known to be at a risk of hypercapnic respiratory failure, the following investigation or procedure is most important. Good. In general, once the target oxygen saturations have been achieved, the oxygen therapy should be? Yeah. Thank you.
Thank you, ma'am.